welcome 1,500 more medical students a year, they won't be GPs for 10 years. So we have to think about how we bridge the gap between now and then, and I think this is a message for all of us.
Stephen Dalton of the NHS Confederation, how do you suggest that gap that Terence Stevenson is describing is addressed?
Well, I think the challenge that we face is understanding that we have no shortage of very bright, dedicated, caring people who want to be doctors, nurses, health professionals, or indeed managers in the NHS. And if, like me, you're lucky enough to be invited on a regular basis, like Professor Stevenson, into their hospitals, clinics and communities, what's always so apparent is the pride that they take. So in many ways, the public shouldn't worry about the fact that we have somehow cut off the flow of people who want to be in the NHS. We don't have a problem with that. The problem is when they feel that they can't meet the demand, see people in time, or deal with the major problem of discharging patients when they're ready to leave. That then leads to the kind of personal and professional frustration which we see reflected in the GMC report.
All right. Well, and against that background, unhelpful at best to have the sort of dispute that we saw between the junior doctors and the Department of Health.
That was unhelpful, and there were no winners and losers in that dispute, and I think that's very important to reflect on. But I think that quite rightly, Professor Stevenson points to the factors underlying perhaps that dispute and the sense of disenchantment that is reflected often in reports from staff, is that somehow it feels like there isn't a sophisticated understanding of what makes the NHS work, and it's not necessarily just about statements about putting money into the NHS. What really we need to do is to get the health and care system in and out of hospital moving in an efficient way. What blocks that system is too many people coming in the front door and not enough people leaving when they're fit to.
Right, you're referring to the problems with social care and the NHS picking up the pieces there. Terence Stevenson, would you agree that it's not about the money? I wonder what you think, ultimately, if we're heading to a sort of crisis point, if we're not there already, then however unpalatable this may be, perhaps we'll never be able to meet patient demand sufficiently. Perhaps at some stage we will have to think further about a rationalisation of services.
So I agree, it's not just about money. It's been a matter of public record that the UK spends less on health than, for example, Germany, that we're often compared to, and has fewer doctors and fewer hospital beds. But you're right, it's not just about that. So, for example, we're undertaking a review. We are listening to trainees. One of the things they tell us is their training's too inflexible, and the GMC's doing a review of that. We could work smarter with better IT. We need to think about...
better IT for patients or better IT in the training process?
A better IT in hospitals and in general practice, so that we can deliver care more efficiently, see people, and that doctors spend their time doing what doctors are trained to do. A very long training is to provide clinical care, see patients, talk to them and treat them.
Right. Indeed. Well, Stephen Dalton, when we spoke to Dan Poulter, the former health minister, earlier, he pointed to training being a real problem because he said, perhaps inevitably it ends up being secondary to service provision. Meeting patient demand has to come first.
I think meeting patient demand always does come first, and I think the GMC and the academic bodies would agree with that too. But I don't think that training is undermined necessarily by the situation that we're in. But I do think that in terms of what people experience is a service which is being asked to do more and more, and in fact is delivering. It's delivering on what it's being asked to do. 1.6 million more operations than 5 years ago. Hundreds of thousands of people seen more quickly in the A&E department, and in mental health, children's services, elderly services, we're seeing more people, and I think that our staff on the front line are delivering what they're asked to do. The problem is we need to see a more sophisticated response from government. There's an opportunity for this relatively new government in the autumn statement to send a message to frontline staff that they understand what the problem is for the NHS, and that problem doesn't lie in just making promises about more money for the NHS. They're often dubious promises too, but actually what we need is a sophisticated understanding of fixing social care, supporting carers, and getting serious about preventing ill health is the way in which we'll keep our NHS alive.
Terence Stevenson, just finally, as you look towards the future, I wonder what you think of these new guidelines that have been released by the Royal College of Surgeons, which suggest that clinicians should take patients through every possible option, even if they believe that some have disadvantages, and then let the patients decide for themselves. It's not doctors know best in the end with that sort of approach.
Well, that's part of a longer journey over the last 2-3 decades of doctors recognising that informed consent means truly informed consent. Our view would be that this test case really brings the law into line with what the General Medical Council have been saying for some time, is that people need to know what are the risks that matter to them, and in that particular case, a mother with diabetes, the judge's view was that was an important part of her reaching an informed decision. So I think that it's a journey we've been on. You're right, doctors do not always know best, and